Good morning. I am Catherine Moore, Vice President of Health Plan Sales for Moby, and I'd like to welcome everyone to the challenge of affordability for care, cost, and coverage. It gives me great pleasure to introduce a very talented panel of individuals who, like at Moby, have affordability of care top of mind every single day. And as a health outcomes company, Moby's founders set out to help members lead healthier lives and require less healthcare services on a daily basis, which ultimately in turn really reduces cost for plans. We have averaged 7 to 8% claim savings on an annual basis, and that's backed by using a Milliman verified randomized controlled trial. As at Moby, we also have all incentives aligned, and as we're helping our participants improve their overall health and reduce utilization, our financial guarantee that we have in place helps with our clients. And with that, I would like to start by introducing the panel. We'll start with Michaelle Solages. She was elected to represent the 22nd Assembly District in 2012 and is the first person of Haitian descent to be elected to the New York State Legislature. She currently serves as the Assembly Deputy Majority Leader, as well as chair of the New York State Black, Puerto Rican, Hispanic, and Asian Legislative Caucus. Also with us is Dr. Nancy Bowler, Research Associate and a member of the Healthcare Markets and Regulation Lab in the Department of Health Policy at Harvard Medical School. Dr. Bowler's research examines several areas related to the organization of medical care, health systems, and consolidation in healthcare markets. We also have Alex Bryson, a staff attorney at the Federal Trade Commission for 10 years. During that time, Alex has led or been a part of numerous investigations into healthcare provider mergers. And finally, we have Dr. Vikas Saini. Dr. Saini is president of the Lown Institute, a nonpartisan think tank, where he leads the Institute's signature process, the Lown Institute Hospital Index for Social Responsibility, which includes measures never used before like hospital racial inclusivity, CEO to staff pay equity, and avoidance of overuse. And moderating today's session is my friend Brian O'Grady, President of Health Plan Markets for Capital District Physicians Health Plan. The full bios on this morning's panel are available on the app if anyone's interested. And with that, I will turn it over to Brian.
Thank you, Catherine. And thank you everyone for being here. Welcome to Albany and the Greater Capital Region. And thank you to our, as Eric described us, the powerhouse panel that we have. We are the only thing standing between you and lunch, so we hope to have a rather lively and engaging conversation. But to kick us off, as we talk about affordability in healthcare and the impact of provider consolidation, some of the things we can do as regulators, as insurance companies, as community overall, I'd like to ask Dr. Beaulieu just to start us off with a few comments.
Thank you, Brian, for the introductions, and thanks to Eric Linzer for inviting me to take part in the New York Health Plan Association annual conference. Rising healthcare costs and healthcare affordability affect all of us, both directly and indirectly. Higher healthcare costs cut into wages and salaries, thus reducing our take-home pay, and they increase our out-of-pocket costs. Higher premiums reduce affordability and coverage rates, thereby lessening the financial protection that New York residents derive from health insurance. They hit Medicaid budgets hard, constraining how we help the most vulnerable. And they impact all of us by crowding out spending on things like education and transportation and housing. Nationally, employer healthcare costs for 2024 are projected to increase 6 to 8%. And that's higher than the average annual increase of 5.6% for New York during the 5 years leading up to the COVID pandemic. Consultants and analysts point to several factors that underlying these projected increases for 2024. Post-COVID catch-up on tests and procedures, an increase in chronic conditions, some of which were exacerbated during the pandemic, higher costs of specialty drugs, particularly the new drugs for diabetes and weight loss, higher costs associated with the staffing crisis, and higher prices attributable to ongoing consolidation in healthcare. As the list suggests, higher costs can be driven by both higher utilization of medical care and higher prices. Increases in utilization are not necessarily bad. For example, when the greater use of primary care helps us to maintain our health, to effectively manage chronic conditions, to prevent the onset or progression of serious disease, and to treat acute illness. But increases in prices are rarely beneficial unless they're offsetting some rising costs and preserving our access to care. Prices for medical care have come under increased scrutiny as healthcare providers have consolidated into large corporations with greater market share and bargaining power vis-a-vis payers. Why and how did this consolidation come about? And what are some of the approaches for reining in healthcare prices and reducing the impact of consolidation on healthcare cost growth? Consolidation in healthcare markets has transpired over many years and through multiple avenues. Hospital and health system mergers and acquisitions have been in the headlines for decades. Consolidation in the hospital industry picked up in the 1990s and led to the creation of large for-profit chains like Hospital Corporation of America, Tenet, Community Health Systems, corporations that have evolved into the large health systems in operation today. Nonprofit systems, including academic medical centers, have expanded their geographic and market reach by scooping up community hospitals. As care shifted to the inpatient setting, from the inpatient setting to the outpatient setting, hospitals and systems set their sights on acquiring physician practices. Through referrals, physicians play an influential role in patient choice of the facility at which they get diagnostic services, medical procedures, and specialty care. Systems initially focused on the acquisition of specialty practices, whose physicians generate substantial revenues by referring patients to system facilities. Soon thereafter, systems began acquiring primary care practices, and those physicians were encouraged to increase referrals to the specialists, thereby further securing the stream of revenues flowing through into the system's facilities. Many acquisitions of physician practices are small, involving only a few doctors, and fall well below the radar of regulatory officials. But cumulatively, these transactions build share in local markets, and they extend the geographic reach of health systems, both of which can translate into enhanced bargaining power. Not all consolidation occurs through mergers and acquisitions. Strategic opening of new facilities combined with closing of nearby facilities contributes to consolidation. Large health systems with cheaper access to capital can expand their presence through the opening of outpatient clinics that offer a range of diagnostic, therapeutic, procedural, and specialty care services. Capacity and service expansions can also occur on existing campuses, for example, when systems open a new cancer center or a cardiac center. Smaller community providers are less likely to have the internal capital or access to cheap capital in order to upgrade their facilities and expand their operations. So over time, if enough patient volume is shifting to the new facilities, the community providers are weakened financially, and they become vulnerable to closure. Thus, consolidation can occur without any changes in ownership. Since these larger systems typically have higher prices, these capital expansions can shift volume in ways that increase spending. From the community's perspective, this transition could improve access and quality and efficiency. For example, new facilities can increase access to subspecialty care and can be paired with the latest technologies. Shared electronic medical records and scheduling systems could facilitate timely sharing of information and reduce the burden on patients in coordinating care. These potential benefits derive in large part from economies of scale and scope and are often touted by proponents of mergers and acquisitions. There are at least three considerations that could lead us to question this compelling narrative of larger scale and scope in healthcare. The first and most obvious is the impact on competition, prices, and quality in local healthcare markets, which we'll come back to very soon and is at the heart of this panel discussion. Two other potential consequences of consolidation are more subtle and relate to equitable access and patient-centered care. Increase in disparities in access to care and health are also possible when new and renovated facilities are disproportionately sited in economically and socially advantaged communities, while aging capital and service line terminations and facility closures are disproportionately occur in less advantaged communities. Second, and much more subjective, but perhaps no less important, there's the potential for disruptions in patient-provider relationships and loss of culturally centered care. None of this is certain. It depends critically on the patterns of investment in impacted communities, retention of local providers, and the degree of local autonomy and preservation of knowledge, relationships, and resources in the local community. Returning to the impact of consolidation on prices, multiple studies by economists have linked consolidation in hospital markets to higher hospital prices. But health systems are different. In addition to hospitals, they include clinics where specialists perform outpatient procedures, primary care practices, infusion centers, and diagnostic facilities. There are numerous possibilities for channeling referrals and leveraging bargaining power across markets. In a recent national study of health systems, colleagues and I compared prices and quality of care delivered in hospitals, by hospitals and physicians inside and outside of health systems. And we found that health system providers receive significantly higher facility and physician payments compared to those not in health systems. Payments to hospitals and health systems were 30% higher on average, ranging from 37% higher in academic health systems to 10% higher in health systems anchored by public hospitals. Similar patterns were found for physician payments. 5 years have elapsed since the time period on which this study was based, during which mergers and acquisitions and facility openings and closures have resulted in further consolidation. Since it's unlikely that these healthcare corporations are going to shrink or dissolve of their own accord or through pressure or regulatory action, we must develop options that will work within the context of the current healthcare structures to ensure affordable care. There have been at least 4 different categories of approaches put forth for dealing with high prices and price growth. And I'm going to draw on a couple of policy papers by Mike Chernew and Bob Berenson and their colleagues to provide a high-level summary of these approaches and hopefully set the stage for the panel discussion. The first type of approach is designed to encourage facility price shopping among healthcare consumers as a means of strengthening competition among providers. Price shopping requires information on prices, somewhat obviously, and some financial stake by consumers in the choice of the provider or healthcare service. Building on CMS's price transparency initiative, efforts are underway to make comparable price data available to consumers. However, finding and comparing prices on the web, even for motivated and knowledgeable consumers, is challenging. There's a lot more that needs to be done to get the price information in a format and forum that is easy to access and use in the time that it's needed. These efforts are complementary to benefit design that sensitize consumers to price differences. High deductible health plans, tiered provider networks, and reference pricing have each demonstrated the potential to lower prices and spending, but not have been widely adopted. While there are successful models out there, implementation will require a considerable amount of work on the part of employers, payers, and plan sponsors. In other words, a lot of people in this room to make them work. The second type of approach involves risk-based contracting between payers and providers and includes accountable care organizations and global budgets. In these programs, providers have incentives to reduce spending below a target in order to share in savings. One way that providers can manage spending is by referring patients to lower-priced providers, a form of price shopping. There's active debate about the long-term net savings of programs, net of administration costs generated by ACOs, and there are concerns that they could incentivize further consolidation. Furthermore, there's no evidence that they reduce prices or slow price growth. However, I think that current implementation of risk-based contracting has been handicapped in an important way. The absence of widespread adoption across public and private payers means that the share of any provider's patients in risk-based contracts can be relatively small. This reduces the expected benefit of implementing organizational and behavioral changes needed to succeed at population health management instead of fee-for-service revenue generation. Coordinated multi-payer ACO programs could leverage economies of scale and scope to increase impact on spending and to spread the cost of design and administration. The third and fourth approaches to dealing with high prices and price growth are regulatory. Antitrust enforcement aimed at reducing anti-competitive conduct includes the challenges of mergers and acquisitions and the use of anti-competitive contract terms such as most favored nation clauses, anti-tiering, and anti-steering. In a few cases, states have approved mergers with constraints on post-merger behavior, and I expect our panelist, Attorney Bryson, will have more to say on that matter.
That's right.
The fourth approach involves regulation of commercial prices, getting right at the heart of that matter. Proposals have been put forth on price ceilings and price growth caps, and some states have begun implementing these for state employee health plans. Regulation of this sort requires timely access to detailed data on prices in order to set ceilings and caps for individual services and to monitor and enforce the regulations. State regulators would likely need to have expanded authority. These approaches are, for the most part, complementary and not mutually exclusive. However, each will require resources to implement. So conversations like those occurring at this conference are valuable opportunities to bring together interested and affected parties to engage on these topics and to chart some next steps toward affordable health care for New Yorkers.
Thank you, Dr. Beaulieu, and that definitely sets the stage for us to have this discussion really about, the overall healthcare costs, what approaches we can take, the government and the marketplace to restrain these costs and additional measures that might be needed. So I just want to remind the audience, I've got this high-tech gadget in my lap. Feel free to submit questions. As you may have heard from Eric a couple of times already today, download the app, send us questions. We'll make sure we get those questions in, time permitting. So Nancy, I'm going to go right back to you as you come off stage. Despite the increases in prices when providers merge, you also hear that there are going to be benefits in terms of improved quality and improved integration of care. Is that true, and does that justify the increase in price?
So the first is whether we can observe if there are any differences, changes in quality. And quality is not this one monolithic thing, right? There's a lot of many dimensions to quality. And the research suggests thus far that the benefits that we were led to believe, to expect from these healthcare mergers and acquisitions deriving from improved integration are not manifesting in substantially better quality and along multiple dimensions. So we've looked at patient experiences in hospitals, we've looked at mortality and readmissions, and then on the outpatient setting, we've also looked at management of chronic diseases and such, and we're really not seeing substantial improvement in these measures following consolidation in healthcare. So we're still waiting for those.
Yeah, we all are, for sure. All right, Alex, I'm going to give you a shot here. When provider organizations come together through mergers, acquisitions, it's often we need to do this to improve efficiencies. We need to do this for survival of some of our facilities. Once again, promote better integration. Is this consistent with what you see when you're examining merger activity taking place in the healthcare system, and does it actually come to fruition post-merger?
Do I see those arguments being made to us? Yes, certainly. And I do want to say thank you for having me. And I do have to make a legal disclaimer that the opinions that I give today are my own. They're not necessarily on behalf of the FTC, even though I work there, especially in this space. So they may be the FTC's opinions. But either way, it's really important to note, at least for me and my job, once a healthcare provider merger or a hospital merger comes to me, we are most likely seriously investigating whether there are going to be anti-competitive effects. And this panel is talking about it, whether the prices are going to go up. And importantly, is it going to eliminate an important incentive to compete on quality? And so once that sort of happens, we try to get a lot of information to figure out if there are going to be anti-competitive effects. But at the same time, counsel for the merging parties are going to make arguments to us that the merger is necessary to either promote integration or improve the quality of care that folks are receiving. And so we do get those arguments, and we do consider them under our guidelines. They're considered under the efficiencies part of the analysis. Now, when we're doing that, it's a two-pronged test, essentially. One, are they specific? They cannot be vague. They cannot be speculative in nature. If they are, we're not going to give them any credit. So I'm sure you guys have seen, or maybe you haven't seen, I don't really know, but when healthcare providers merge, usually there is a statement in the press about how they have a vision that the merger is going to improve integration, it's going to improve quality. They never talk about anti-competitive effects, believe it or not, in those types of statements. But if it's just sort of those vague assertions that everyone's going to be under the same roof, therefore quality is going to get better, we're not going to give any credit to that. But then secondly, and probably more importantly, is whether the merger is necessary to actually achieve whatever the benefit is. So if for some reason we do have a very specific argument, and maybe it's we're going to put everybody on the same EMR, that EMR leads to higher outcomes in terms of quality of care, and so there are going to be tangible benefits. Well, we would ask, well, can you achieve those benefits, higher quality of care, some of the measures that Nancy was mentioning, without the merger? Or could you move on to the EMR without the merger? What's that look like? Or, and probably even more importantly, could you get a different merger partner that maybe would install the EMR or lead to the quality benefits that doesn't also have anti-competitive effects through higher prices and potentially lower quality? So that's sort of the lens that we look at it through. I think it is also very important to note that even if we do have what I think of as a cognizable efficiency, one that counts for our analysis, that does not mean that the merger is okay. It's probably pretty unlikely that it's going to dispel our concerns, especially if there is very little competition left in the market, or we think there are going to be significant price increases. It's just not going to be enough to sort of dispel or offset our concerns there. But yes, I do hear those arguments frequently, and I'd say they rarely have merit.
And is there any follow-up post-merger? Is that just then for the marketplace too?
Yeah, so we
wrestle with
that is not something that we do. I guess the caveat is we did lose a lot of hospital merger cases early on in the 90s. And then we had there was a Bureau of Economics at the FTC, full of a bunch of very smart economists, like Nancy here, who do their research. And we actually did some retroactive studies that showed the mergers that we challenged and lost did in fact lead to much higher prices, which was a sort of path forward for us to then win some of our cases. So we do some retrospective analysis then. I do not believe that BE has done any on quality, but as Nancy mentioned, there are a lot of papers out there by economists and other researchers that do indicate that quality is not improving post-merger according to the promised benefits. And in fact, I think in a number of cases, there are a number of mergers qualities actually going down, which you might expect if you are in fact having an anti-competitive merger that does eliminate an incentive to compete on quality. It wouldn't be surprising if quality does go down or does not improve as much as it should.
Thank you. Thanks. Dr. Saini, at a time when hospital prices are among the major drivers of rising healthcare costs, the Lown Institute's research has indicated that most not-for-profit hospitals receive more in tax breaks than they spend on charity care and their community investments. Are there steps the marketplace or the policymakers could consider to ensure these institutions are fulfilling their charitable missions?
Thanks for the question, and thanks to Eric and the association for having me here. As was pointed out earlier, we published the Lown Institute Hospital Index for Social Responsibility, and part of what we look at is community benefit spending. We compare that, or we've started comparing that to tax breaks that hospitals, nonprofit hospitals enjoy, and we've consistently found that by and large, nonprofit hospitals fall short. Now, in their defense, I would say that the issue really is that we're dealing with something, as our professor from Cornell pointed out, that's accumulated over decades, if not generations. The concept of nonprofit status, the ethic, the vibe, if you will, if you're a Gen Z person, really is about 100 years and counting. And the core thesis for us in putting this hospital responsibility index together was, maybe it's time for a change. Let's rethink what this looks like. And so part of the problem, I think, is that our conception of what's appropriate behavior was perfectly valid in 1910, maybe 1920, maybe even 1945. But certainly with the post-war boom and the birth of what Bud Relman at the New England Journal called the medical industrial complex, times are very, very different. And so I think we need a sea change in how we do things. So if you wanted to ask our opinion about what could be done differently, there's a lot. I mean, we could start just by saying you could set a minimum threshold. There is absolutely zero requirement that there be community benefit spending. It could be $1 and you're good. So the reality is when you're dealing with billion-dollar businesses, that's probably too lenient. And so that would be one. Very radical position, I guess, but more and more people are taking it, like the state of Oregon and others, because I think these kinds of things are on the way. And I would say that our work, which is very modest, has gotten a lot of traction from state and local and county officials, I think for those obvious reasons. So setting a minimum is one. Tying it directly to community health needs, directly the spending to community health needs, is another. We would favor, though it's self-interested, we would favor disaggregating system level spending so we can actually see at a facility level what's going on, and more importantly, so communities in those areas can actually see what's going on with community benefit spending relative to the tax break. And then there's several things that could be done that are not directly around community benefit spending, but directly related to why that category even exists. For example, predatory billing practices. If you're going to have a nonprofit status, then it may be perfectly reasonable to ask questions about what your financial assistance policies are, whether or not you send people to collection, even though they might have met financial assistance policies, but were never properly offered it. Just one example. Do you deny medical care to somebody because they have medical debt? If you're a nonprofit and you're purporting to serve the community, I think there are reasonable questions to ask there. And then lastly, but I'll go there, is, some of these nonprofit businesses are indistinguishable from for-profits, and everybody in the biz knows this. I should say, you could read my background online, but I practiced both in academic settings in the Harvard system and in a community hospital. I ran a primary care network that took global risk contracts. So I've talked to a lot of people in many different sectors. And, it's hard to distinguish nonprofit and for-profit behavior. So maybe it's time to look at CEO compensation in relationship to social responsibility. I'm not saying what the right number is, but maybe it should be more than beds and heads.
Thank you. Thanks. Assemblymember Solages, what impact do rising provider prices have on the constituents that you serve? And are there approaches you'd like to see taken to address hospital pricing or address the impact of provider consolidation?
Yeah, definitely. And, I just appreciate the opportunity to have this conversation because we are going through an affordability crisis. On the ground, people are in survival mode. They're choosing between whether to, pay for groceries, rent, basic necessities, and they're deferring or delaying healthcare treatments. And so the impact is financial strain. The impact is a lack of access to adequate care, and we see it. And, I represent Long Island, which is a special place. We do say water and dog really weird. And we're very vocal and strong. But, as I said before, regardless of your political persuasion, people are having that conversation about the cost of care. I had a gentleman in my district. He's a very, conservative Republican. And he came up to me. He said, I don't agree with Medicaid for all, but we need to control the cost of health care. He said he went into financial debt because he had, a medical emergency. His wife then had a medical emergency, and then his son had a medical emergency. And he had to borrow money from his parents. And this is a gentleman who's probably, 60, 70 years old, having to borrow money from his parents. So this is a real conversation that we need to have in our communities. And so this session, we actually passed a bill, and I'm hopeful that the governor signs it. It's not if, it's when. I'm an optimist. But it would cause the Department of Civil Service to collect healthcare data such as pricing and utilization and publish a report on pricing. And this is exciting because we will now have, on some type of level, a lay of the land, a way to look at pricing across the system and see what we can do to make sure that we have affordable health care. And that's the key. We want to make sure that people have access to care because this is a matter of life and death. And as New Yorkers, we are, a big tent. We believe that we need to protect each other. We are welcoming, but we can't have this system where people are just not getting medical care because they can't afford it.
Thank you. Thank you. For Dr. Saini and Dr. Beaulieu, we're sitting here in capital New York State, and we, especially those of us doing business in the state, know how we're handling or not handling these types of situations. So are there states that have had a greater impact on controlling the impact of provider consolidation and rising hospital prices better than New York? And are there lessons we could learn from other states?
Go ahead.
I don't know that I could say that they're better than, but there are some states that are out there leading the charge on trying to implement some of these price ceilings and price caps. So Oregon has been out on the forefront at trying to manage and deal with provider consolidation, even going to the point of doing requiring some reviews when those events come up. And Rhode Island is another state that has really started to push on establishing affordability standards, which with some additional authority that's granted through legislation to really start to put the nuts and bolts in place to try and manage healthcare prices, if not, going into detailed review of the events themselves. But there's got to be some capacity that's built in at the state level to have the data that you need to know the variation in prices. You need that kind of data in order to be able to figure out how to set these price ceilings or price cap, growth caps, if that's the direction that you're going to go. And so I'm very happy to hear about the legislation that's moving forward in New York.
And then there are institutions like healthcare policy commissions that can do analyses, that can help the legislators and policymakers understand where the populations are that are being hit the most, hardest, to figure out how to get them some relief. So I think those, the data and building some institutional capacity, I think, is probably some important first steps.
So on the data side, I would second what Nancy said. California is trying to beef up their effort with HPA, what's that, Healthcare Accountability and Information Office. New York City passed this legislation to create an Office of Hospital Accountability. Those are by and large oriented towards the transparency side. Until you know what's going on, it's hard to take action. So that's quite important. But that's really a necessary but not sufficient condition to really get there. Connecticut is I forget if they've passed it or not, but they're looking at anti-competitive contracts. So this is after the fact. They're actually getting in your underwear, looking at what the contract says. And I think it's going to take that level of scrutiny. The Massachusetts Health Policy Commission, to my mind, has not had the enforcement strength that it could or should have, or that was originally intended. So I think health policy commissions need a lot of beefing up. And really, at the end of the day, I think the action has got to be more at the level of the state AG and, maybe our friends at the FTC. But, there I think there's real opportunity to intensify market overview. And by that I mean not just at the threshold of consolidation, although even there I will say in Massachusetts the AG's office has created conditions for consolidations that require significant investments in other dimensions of care. Is it the best possible thing? No, but it's decent. But really, things like looking at the role of private equity and other actors in the marketplace that are not directly about consolidation and price, that are nevertheless going to have a huge impact in the market. I think those are all elements that are part of the picture.
Great, thank you. All right, Alex, this is a question written by an attorney for an attorney, read by a layperson. So last year, the FTC issued a report warning state lawmakers about shielding hospital mergers from federal antitrust scrutiny in exchange for prolonged state oversight. What are the shortcomings of these types of state activities, and are there approaches that state policymakers should consider to ensure that future provider mergers or acquisitions don't lead to higher prices? Additionally, are there areas where states would be limited in what they can do compared to the FTC?
So I just want to follow up on something the doctor mentioned at the end there. We are happy to work with the state AGs, certainly for our investigations, and we frequently do for our joint investigations. To the extent they could do things beyond the federal antitrust laws, I certainly support that as well. And I know that New Hampshire's had some success lately, at least working without us. We do have limited resources at the FTC. We don't have that many attorneys. To get to the question, all right. The question, which really specifically talks about COPAs. What is a COPA? It's a Certificate of Public Advantage. What does it do? And essentially what happens is two healthcare mergers, most likely at hospitals or hospital systems. They want to merge. I'm not privy to these conversations, but they probably talk to their attorneys. They probably have antitrust attorneys, and their antitrust attorneys probably tell them this merger is blatantly anti-competitive and it's going to be very difficult to get this through. And so they think of other ways to get their merger through, and one of them is completely skirting the federal antitrust laws. How do they do that? They go to the state legislature and get them to pass what is called the Certificate of Public Advantage law, or maybe the law is already on the books, and they get a Certificate of Public Advantage by telling folks essentially, we want to merge. It's going to be incredibly beneficial to the community. integration, quality, all those things that I mentioned. And on top of it, we are going to give you plenty of oversight onto the pricing aspect so that you can control prices. And then we're out of the picture, and actually I think probably there are state antitrust laws as well, and I think they're also out of the picture. And so then the providers merge, and then what happens? Well, the COPAs usually do not work, is what happens. We've done some retrospective studies on this, just like we did for the hospital mergers that we lost. And BE has found pretty conclusively that prices are going up despite the assurances in the COPAs, and significantly, not a little bit. We're talking 20, 30+% in terms of price increases, which is, again, not surprising because the mergers that typically seek a COPA are particularly egregious in terms of probably being anti-competitive. Sort of taking a couple steps back here, thinking about the COPA, it is what I think of as a behavioral remedy. And I think of two potential remedies to any antitrust case. This isn't limited to healthcare, but one I think of as structural, and one I think of as behavioral. Structural is, if it's a large business, you essentially have to divest whatever pieces of it are anti-competitive. So whatever pieces where both companies are competing in the same area for the same products with limited competition, you got to sell it to somebody else so that competition is preserved, and we keep those benefits. That's a structural. The ultimate structural remedy is completely blocking the merger. You cannot merge at all. The behavioral side is conditions on a merger, or essentially the COPA, so state oversight. We in theory could do something similar and say, yeah, we will engage in federal oversight of your merger to make sure that prices don't go up. We don't do that. There are several reasons that we do not do it. One, it is incredibly resource intensive. Like I just said, we don't have very many attorneys to do the job that we have to do, and we can't spend a lot of our time making sure that post-merger prices aren't going up or firms aren't behaving anti-competitively. And then second, probably very apropos to this question, they don't work very well. I am not aware of very many behavioral remedies that we have done that have, in effect, preserved competition. It just does not come to mind as something that works, and that's what BE has found in its studies and in the papers that are available online at the FTC. So my advice, if you want to preserve competition and the benefits of competition, lower prices, more incentives to compete on quality, better quality healthcare, do not engage in a COPA. I think it's a pretty straightforward analysis. Instead, try to keep anti-competitive mergers from happening.
Thank you. Assemblymember Solages, you talked about the motivation for the legislation that you sponsored regarding transparency. So follow-up question to that would be, what else can we do along the lines of transparency? Because as you know, the hospitals are required to post their prices on their websites, and it's tough deciphering what they actually post. So how can we improve that? And then are there any other legislative priorities that you have to address rising costs?
Yeah, as we said before, it's, accountability, giving people the opportunity to make informed decisions, making sure that we eliminate medical debt, that people know that when they walk into a medical facility, they see the pricing. There's a lot of proposals on the table. And so it's really exciting time because we're having these conversations. From a basic level, people are exploring expanding telehealth. Because we know that there are places in the state where access to medical care is limited, whether it's upstate New York or even in urban areas, access to specialists are not available. So we're having a real conversation around telehealth and also making sure that it has parity with the funding. What else? Oh my God, there's so much. I could be for hours talking. Another proposal is really also talking about capping the prices. I think that's a long-term conversation that we need to have. It's a serious conversation that we're going to have, but at the end of the day, it's a necessary step in controlling costs. And it's also about transparency. I think government is better, business is better when we have these transparent conversations. So, I see the time card coming out and I saw lunch rolling up. So,
I just look over my shoulder for Eric at the podium.
And like I said, I could sit here for hours talking about the different proposals, but at the end of the day, I'm just happy that we're having these, serious conversations about access and affordability.
Great, thank you. So, all right, we're probably going to be kicked off the stage soon, so let's do a quick lightning round here. And we'll start with Dr. Saini and come down the line. Are there approaches that health plans, employers, or other purchasers are pursuing in other parts of the country that we should consider in New York State to help mitigate the impact of past mergers and hopefully, protect ourselves from any potential future mergers?
Go ahead.
That's a tough one. I don't think I've seen anything or heard of anything that is already, that's showing any demonstrable impact. I think what's clear is to the legacy of the FTC in the 90s, what's clear is that people have come to a conclusion about this. The efficiencies, all of that stuff ain't so. It's mostly about price rises. And so now I'm just going to talk my book. I mean, my bias is really that if you're going to have a 30% increase in price, and I want to see a 30% reduction in risk-adjusted mortality, you show me that, I'll pay you that money. If you don't, give it back. I mean, I think there are ways we got to start thinking about this very, very differently, and I don't pretend to have the answers.
Dr. Beaulieu?
I think there are some things that are happening in other states that, that we did discuss earlier. But I agree. I think that we have to have open conversations with data. If your prices are 30% higher and they're going up 5 to 10%, then what are we getting in exchange for that? And I think that those discussions have to be open to the community. I think the reputation of those institutions have got to be online. They've got to be held accountable to the public that depend on them.
Can I just add one thing about accountability to the public? I just can't resist with a captive audience. About 6 months ago, I was, surfing YouTube, and I came across this stand-up comedian. It was Brooklyn, so what the hell? It's Brooklyn. But he's going on about all sorts of things in life, his pants, his girlfriend, whatever. And then at one point, he starts talking about healthcare, and he opens with, healthcare in America is a criminal enterprise. Now, question is, what do you think the audience reaction was? It was stand-up cheering. And this is not 2 people. This is 500 to 1,000 people. So I'm just saying, the bell is tolling, folks. And last night, since I had nothing else to do, having driven from Boston, I get on Netflix, and I have this other stand-up comedian, different guy, different location, and he goes on about American healthcare is dystopian, man. And then he launches into medical debt, all of that. It's out there. So we need to have a sense of urgency here.
Thank you. Somebody remember?
Yeah, just to reiterate, the states are really the boiler rooms of democracy, and we see all across this country, a real look at what we can do to improve outcomes, especially amongst some marginalized communities. And so, it's nice to see that even, attorney generals are now having these conversations. So I saw that the California Attorney General is now instituting conditions on certain mergers and items. So they're requiring, hospitals to maintain services, because we see now more than ever a lot of hospitals are closing their maternity ward, their specialty ward, and also making sure that there's a conversation around pricing. So, as a state legislator, I think, looking at the states and looking what we can do to improve outcomes is where we should be putting our focus.
Thanks. Alex?
Past mergers, I have not really seen much that has
We're stuck, huh?
effectively been done to address them. It's sort of, they made changes to the antitrust laws a long time ago, but essentially unwinding a merger, they always do this analogy. You guys probably haven't heard of it because it's not a legal conference, but they call it trying to unscramble an egg. And I have never tried to unscramble an egg, but I think if I did, it would not be successful because it's impossible. And unwinding a merger it's either as close to impossible as unscrambling an egg or incredibly difficult. So I haven't really seen much that sort of addresses the past mergers. Going forward, please, by all means, if there's an anti-competitive merger happening, I think we have an email that you can send to us. You can call the FTC directly. You can call my boss, Mergers4, at Mergers4, Mark Simon. I'm sure he'll be really happy that I just gave out his name. And also call your state regulators. Call your state AG's offices, because they usually have folks. They don't all of them have folks that deal with antitrust, but they usually do. And sometimes we find out about mergers, not only from the community and the third-party providers that will be affected, but also from the state AG's offices. And so the more that we can become aware of these things, the more that we could do before it's too late.
Great. Thank you. I want to thank the panel. I want to thank everybody who submitted questions. I apologize to those of you whose questions I didn't get to. I also, and meaning no disrespect to the commissioner, I think we will remember what we talked about today because, we said this morning that you go to these conferences, you don't remember anything that was said. This panel, I think, was very impactful, and it's something that we face day in and day out, regardless of what part of the industry you're in or whether you're a consumer or not. The affordability it's untenable. So thank you all for your time today.